The broadcast is now starting. All attendees are in listen-only mode.
Good morning. It's 10 o'clock. My name is Kevin Hsueh. I'm one of the directors of the MASEC project. Thank you everybody who's able to attend today, this final case conference for the 2019 MASEC season. Mike, do you want to switch to the next slide? So today we'll be having a case conference directed by Michael Durkin, one of the other directors of the MASEC project, with myself and Aaron Rockmiel as the discussants. Reminder that this is a Poll Everywhere interactive session. So if people could go to their Poll Everywhere website and start logging in, that would be helpful so that you can respond. So I'm going to hand this over to Mike. Oops, what just happened? Mike, it's off to you now. No one can hear you. Hold on, we appear to have some technical problems.
Okay. Hey, Kevin, I just got off from the page.
Sorry. So Mike Durkin is going to be our discussant today. He's an assistant professor of medicine in the Division of Infectious Disease at Washington University School of Medicine. Mike,
great. Would you like me to start? All right.
Off to you.
Great. So I have no financial disclosures. Once again, this is an interactive session, so please log in to Poll Everywhere and make sure this works for you. I included a lot of interactive aspects to this with a lot of word clouds and free text. So I'd really like you to participate because for some of these, there's no right or wrong answer for them. So we'll also be asking our discussants, Dr. Hsueh and Aaron Rockmiel, about what to do in these more ambiguous cases where we're not exactly sure what to do.
We haven't heard anything about these cases too, so this is going to be totally new for us as well.
Yes. All right, we'll see what you guys think. Okay, wonderful. Looks like it's working for participants. I really look forward to hearing your responses. So we'll get on to the next slide here. So in terms of updates, funding, as Kevin mentioned, is ending by the end of the month here. We did hear that the program was well liked by webinar participants. The Missouri Department of Health and Senior Services submitted a renewal grant, as we talked about, but unfortunately it wasn't funded. We'll try to work with MHA and the Department of Health and Senior Services to see if there's other funding mechanisms for this as well. We're wrapping up analyses on feedback. So far, the information that participants have given us included providing more handouts and templated materials, better engagement and opportunities to communicate. We're going to try to incorporate more of those and potentially continue to provide you some services, potentially through a statewide stewardship listserv. So expect to hear more about that in the near future. So we'll get right into the first case discussion. This was a patient I saw on service actually last week. So it was a very challenging case. And I'd love to get feedback from you guys about how you would handle this. So he was a 36-year-old male with a history of MS and type 2 diabetes that was reasonably well controlled on oral medications, who presented with worsening back pain. He was initially seen at an outside hospital for Cauda equina syndrome, and they placed 2 artificial discs in his lumbar spine. Per records, this was complicated by an infection. He got several washouts over the last 6 months and has essentially been on antibiotics for almost the entire time. When he presented to our hospital for a second opinion, he had a PICC line in place. We reviewed his microbiology labs. None of the labs corresponded with any operative cultures, but were mostly swabs and drain cultures. Of the data that we had, organisms that grew included E. coli that was fairly susceptible to most antibiotics, a Pseudomonas that was pan-susceptible, MRSA, and mixed organisms. He has an extensive antibiotic allergy list too, to penicillin, vancomycin, ertapenem, and sulfa antibiotics as well. And in the past, he's received daptomycin, vancomycin, cefepime, ceftolozane, tazobactam, or Zerbaxa, ceftriaxone, doxycycline, and metronidazole. He's tolerated all of those in the past as well when he received them. His most recent antibiotic regimen, when we saw him, he was on doxycycline, levofloxacin, and metronidazole. When we were consulted, the primary team placed him on daptomycin, aztreonam, and metronidazole. So we'd love to hear from you what stewardship issues you see in this case. You can start answering. I'll scroll up one slide so you can actually review the review this data while you're trying to respond and think of stewardship issues.
Yeah, Mike, these are some of the most challenging kinds of cases where you have an abundance of data, but not entirely the perfect data, right? If we had operative cultures information, we could tailor antibiotics to that, but you don't. If you had more detail about, oops.
Oh yeah, people can start answering now. They've got a chance.
Yeah.
Yeah, keep going, Kevin.
If you had more information about his penicillin allergies, you could probably tailor the antibiotics to some of that.
Yeah.
Was this supposed to be a word cloud?
It is this one's a word cloud, yeah.
Okay.
So for people that respond to try to make it one word responses if you can. I see allergies, resistance, proper assessment.
Yeah.
Pseudomonas in there too.
So aztreonam, I think somebody picked out that aztreonam is always a concern, simply because it is not a particularly broad spectrum agent. It's broader than some of the other non-beta lactam gram-negative agents, but only very slightly. Source control, somebody or multiple people look like they've documented source control as issues, and absolutely that's a huge issue here. So, you know, so they have him on
slide then.
Yeah, they have him on Dapto. Dapto. Sorry, I'm going off memory. Mike, what was it? Dapto,
aztreonam, and metronidazole.
Metronidazole. So, for cultures that aren't entirely certain, what they are. So, I mean, as an empiric broader spectrum coverage, it's somewhat sensible. But the biggest problem is he's been on very broad spectrum coverage, with the doxy, the levofloxacin, and I forgot what the other, and probably the metronidazole, and he hasn't improved. And there's no real way to know if the change in antibiotics is actually going to do anything. In the daptomycin surely is broader than doxycycline, but aztreonam, over levofloxacin is not that much broader, and then metronidazole, of course, is not different one way or another. So really, the big thing that has to be pressed into the primary team here is that in these cases, identification of organism is critical, because otherwise you're just chasing your tail. You're doing this, you're doing exactly the definition of insanity. The same thing over and over and over again, hoping for a different outcome. And so you need to impress on them that even if he's feeling worse, this is a critical time to actually get a culture perhaps off antibiotics operatively to identify what bacteria you're actually dealing with.
I think those are great points, Kevin. Aaron, can you chime in? Because some of the things that Kevin is recommending starts to lean in towards more clinical decisions where pharmacists might have a harder time talking to physicians in particular about recommending things like surgical interventions. What are your thoughts about approaching this?
If I was rounding with a team or sitting in the pharmacy and got these orders, I think the first thing I'd be trying to contribute is what can I find out about those allergies? Because that long list of allergies narrows your antibiotic choices that you're going to have later. So seeing if there's any, because sometimes as pharmacists, I might have a little bit more opportunity to try to get my hands on some old records, some old documentation or something just to clarify what those allergies are and if they're really allergies.
Yeah.
So that's probably one place I would start.
Yeah, and there's already a hint, right, that he probably is, the allergies aren't as significant as we, would fear, because he's tolerated third and fourth generation cephalosporins.
Oh, good point.
He's tolerated vancomycin, and so it's unclear if he actually needs to be on aztreonam or dapto. And then we have limited culture results too. So yeah, choice of agents, I agree with you, Aaron and Kevin. We probably can narrow some of the antibiotics down to more appropriate therapies. We talked a lot about pharmacology and other things, but there is one aspect of this that is challenging too, is whether or not, if you wanted to start pulling off antibiotics, what would you do in a situation where they're on dapto, aztreonam, and metronidazole? Because aztreonam doesn't have good gram-positive coverage too. So losing or pulling off the daptomycin may limit your coverage for normal organisms, including some of the mixed pathogens that were identified in those culture results too. What about approaching the physician and duration of therapy? It's probably a little too early to know duration of therapy at this point, but clarifying allergies and then maybe trying to approach the physician to find out if there's a plan rather than just continuing the antibiotics forever, which appeared to be the plan from the physicians of the other hospital. Great.
Yeah, I mean, I think always, especially as somebody who's on multiple antibiotics, that's also one of the things that I always look at is what is the plan? What is your expected duration? And I always would just start by asking that question,
Yeah, so we already talked a lot about some of the things that I brought up. Maybe vancomycin would be okay. He's tolerated cephalosporins. Challenge with de-escalating with limited data. You trust the culture results. Kevin, what are your thoughts about those culture results? And Aaron, what do you think?
So, I mean, we run into this problem all the time. Cultures taken from external wounds or older drains are often, for lack of a better term, they're useless. They grow, bacterial organisms that grow on wet surfaces, not necessarily anything that's invasive, but colonizing organisms that will intrinsically get on any wound simply because they're open to the air and the environment and wet. So oftentimes these tend to be very highly resistant gram negatives, sometimes anaerobes, and some gram positives, especially enterococci. And oftentimes it's not particularly helpful because they're not the organism that's invading. So this actually can lead you down a rabbit hole of chasing those organisms and the coverage for those organisms while you're actually going farther and farther away from probably what is the true pathogenic organism. So I would view them highly suspect. And I'm not sure there's any evidence except for maybe with Staph aureus that they're of particular use.
Yeah, that's a great point. I also was confused when I saw him why he had a PICC line too. They discharged him on oral antibiotics, but he's had a PICC for about 6 months as well, which puts them at a higher risk for infections too, including bloodstream infections as well. So there were a lot of opportunities for improvement. And I think evaluating lines is important, and it's a good area of synergy between infection prevention and antimicrobial stewardship. So infection prevention is look at line days and try to remove central lines that may not be necessary, because it does place the patient at risk for central line associated bloodstream infections. And those lines, if they do get infected, the hospital leadership care about that because it affects quality metrics and in some cases reimbursement as well. Removing unnecessary lines or lines that aren't currently in use can help from a stewardship perspective prevent potential infections, and an infection prevention perspective too. So I wear both hats, and I really love it when the infection preventionists and the stewardship people work together. There's a lot of potential synergy there. So if you haven't reached out to your infection preventionists to work with them on quality improvement projects, there's significant overlap with PICC lines, with Foley catheters, with blood culture contamination too. So that's just kind of an aside as well. So speaking of what Kevin had already mentioned, culturing drains is not particularly helpful. So this is a study from 2017 where they routinely cultured the tip of drains after spinal surgery. And these patients had no concern for infection, and they were trying to figure out whether or not a positive tip culture could predict whether or not someone had surgical site infections. So they looked at 340 patients for 3 years. They had 34 positive tip cultures. They had 19 surgical site infections. So on the right-hand side, you can see a table that's got drain tip culture, positive and negative, and then surgical site infection, positive and negative. So you can, and then at the bottom table there, you can see, based on that 2x2 table, they calculated sensitivity, specificity, negative predictive value, and positive predictive value. And overall, they're pretty poor, suggesting that obtaining cultures, even from uninfected areas that would be as clean as possible, didn't predict surgical site infections. The one that they would care the most about in this study would be positive predictive value. So would a positive tip culture predict whether or not they had an infection later? And only 29% positive predictive value is pretty poor overall. And I think you can easily extrapolate this data out to cultures for drains that have been in place for a prolonged period of time. The longer someone's got a drain in place, the more likely that drain's going to be colonized with pathogens. And those organisms don't necessarily cause infection. They could just be colonizing the drain itself. So it makes it particularly challenging for us to evaluate whether or not a positive culture from an old drain means anything. And for Kevin and myself, usually we ignore those results if it's from a drain that's been in for a prolonged period of time. If it's a drain from an abscess that was placed that day, or they obtained cultures immediately after the drain was placed, I'll trust those. But beyond that, especially the longer the drain's been in place, the less likely I am to trust the results.
And realize that this is talking about tip cultures, where they basically pull out the drain and then just swab the tip, or they somehow sample the tip of that drain, something that's been sitting in the patient. Most of the cultures we get from drains are actually fluid drawn out of the drain. That means any bacteria in that entire drain is going to get into whatever culture you send, which makes all of this likely much worse for those kinds of cultures.
Yeah, absolutely. That's a great point, Kevin. Even here, we're talking about 10% of cultures in ideal circumstances being positive. If you culture a drain, especially the exterior aspect of the drain, from like a JP site or something like that, you're almost certainly going to have a positive result. So it makes it very challenging to know what to do with. That's probably a difficult position for stewardship pharmacists too, though, because a lot of clinicians feel compelled to treat a positive culture result. Aaron, what approach would you take if you saw a physician that may have done this over the weekend and you hadn't chatted with them, or you weren't aware that they were going to obtain one of these cultures, and they ended up getting a culture that turned up positive, but you suspect it's a colonizer or a contaminant rather than a true infection, or you don't think the culture results would be helpful for directing antibiotic therapy? How do you approach that situation?
Well, I mean, I think as almost all of my interventions would start out with, it would be a question. I saw that you got this culture, and I'm just wondering what you think the significance of this is. Do you really think this is something that we need to treat? And then let them explain what their justification is. Maybe there's some other information that I don't have access to, because that happens, So maybe there's some other information that they're using in conjunction with the culture data that I'm not aware of. But then if they come back and it's not, and it's just this one culture that we think, is more likely to be a colonizer, then I would ask them that question and see what they say. And if again, it depends a bit on the physician and how they respond, and also sort of what my history and their history is. But if it's somebody that, is, that I think I'm going to be able to convince, I would go and get the data and show them, something like this or some other data about, what the likelihood of that type of culture being a contaminant is, and try to convince them with literature.
Yeah, it's challenging. There's not a lot of literature in this setting when I looked it up yesterday. But that's generally the view of most of the ID providers, is that a lot of these cultures, especially from drains that have been in place for a long time, represent colonizers instead of true pathogens. Sometimes it's challenging because you have to work with what's available, which was the setting here too.
And don't get discouraged either. I mean, we have a lot of ID providers who run down this same logical fallacy, because it's the only information present, and that's the really unfortunate thing, right? It's information that is it is misleading, so it's even worse than having no information.
Yeah, I guess in that setting, you might ask the clinician, what their suspicion is of this being a contaminant versus, or a colonizer versus, causing the patient's infection, and if they think that potentially placing a new drain would be useful. Our interventional radiologists will place new drains if someone has an infection and that drain's having any issues, or there's output problems or other things too. They probably would work with us to try to exchange the drain if we thought that that might have represented a colonizer instead. We do that with Foley catheters too. So in our hospital, if the patient has a Foley catheter and a doctor thinks they have a urinary tract infection, the protocol is that the catheter gets exchanged, and then the culture specimen comes from a new Foley catheter tube instead, to reduce the chance of false positives from colonizers on the tubing. So back to our. Oh, sorry. Yes, go ahead, Erin.
The other thing that I would say is also, if they're going to do it, make sure they can say sort of what they're following and what their endpoint is and what the plan is, so that at the very least, try to get a plan so that there is an endpoint at which you're going to stop it, so it doesn't just go on indefinitely.
Right, that's a really good point, because sometimes it really does go on indefinitely.
Yeah.
So here's the update. The following day after they were admitted, they spiked a fever. So
that's unfortunate.
Yeah. So now they're on daptomycin, aztreonam, metronidazole, and they've spiked a fever. And your hospitalist asks you what to place the patient on. I think this is a word cloud again. So just type in the individual name of the antibiotic.
You're really putting people on the spot. This is not an easy answer. I don't think there is. So this is exactly one of those cases where there's no right answer here, people. because there really isn't.
Yeah, we struggled with this too.
Honestly, one question is, do you put them on? Yeah, that's actually a really good point. So he's not on the yeast coverage. I don't think he has gotten yeast coverage. And yeasts, in particular Candida, can be very difficult to isolate, especially if they're growing on the surface of hardware. So that's a possibility. Vancomycin, supposedly he had an allergy, but I think he also had received it as well.
He did receive it and tolerated it in the past. That's correct.
He's
Yeah,
also
it's possible.
So
Yeah.
one thing about Vanco, though, in a patient like this, he's very young, right? He's like 30 something-ish.
36.
Yeah.
Yep.
So Vanco can be really difficult to get therapeutic if you're targeting MRSA in a patient that's 30, that's below essentially 40-ish years old. Oftentimes the renal function is such that even with incredibly high doses, 2 grams Q12, or sometimes even more frequently, you don't get appropriate levels to kill off MRSA. So just be cautious about that, especially if he's already on a broad spectrum gram-positive agent like daptomycin. I think he was on daptomycin.
Yeah, Vanco might be a good choice if you were worried about Corynebacterium striatum that can develop resistance on therapy. Clindamycin, I think, makes sense, especially if you were about necrotizing fasciitis too.
Yeah, absolutely.
That would make sense. So I was worried about his gram-negative coverage because he'd received a lot of previous antibiotic exposure. So he's at high risk for resistant gram-negative. So cefepime, I think, makes a lot of sense. Aztreonam, it doesn't have quite as broad a coverage as cefepime. So I think cefapime's a good choice too. I was personally a little worried about maybe ESBL pathogens or even CRE since he's been on antibiotics for 6 months. So my management was similar to what you guys had discussed. And unfortunately, it hurt me from a stewardship perspective to put this patient on this. But I put him on daptomycin, ceftazidime, maybe Bactam, which is also called Avicaz, which has good coverage for ESBL pathogens and CRE. I added micafungin on too because I was worried about yeast. We usually like to use micafungin over fluconazole for our sick patients or patients with lots of healthcare exposures because they tend to have, or they're more likely to have fluconazole-resistant yeast organisms.
Non-albicans candidemias or candida infections.
So the next question is, where do we go from here? This is my worst stewardship nightmare here because I know that my stewardship pharmacist is reviewing these antibiotics and she's looking at me like I'm crazy here. And am I going to have to sign off on this patient with this crazy antibiotic regimen too? So we talked with the other doctors and we decided that we probably need to figure out the extent of his infection because we weren't sure how severe it was, if he had source control issues. So he had imaging, a CT of his abdomen and pelvis that showed there weren't any fluid collections that we needed to go after or anything to drain. So they actually took him to the OR to explore the extent of his infection. We removed the PICC line after he spiked a fever. He started growing gram-negative rods in his blood too. So that was suggestive that we might be able to narrow his therapy as well, and gave us an opportunity to potentially narrow things too.
That's great though, if you actually have a blood culture, because that's a sterile site culture and you can actually hang your hat on that generally.
Yeah, absolutely. Yeah. So the blood cultures ended up being positive for Acinetobacter species. The OR cultures are still pending, but they didn't see any evidence of gross infection. It was mostly scar tissue. They took plenty of cultures for us. We always try to tell them to take cultures while they're in the OR, specifically from sterile sites if possible, so we don't have to deal with these contamination issues or colonizer issues. So his current therapy is daptomycin, ceftazidime, avibactam, micafungin, and metronidazole. So next steps after this. We've got some information. He's on a really very broad spectrum regimen right now. What do you think, Kevin and Aaron?
You're not making things easy. I will say that I actually think, if I'm remembering right, that ceftazidime avibactam is not actually that good against Acinetobacter. Unless I'm forgetting, I actually can't remember if it is or isn't. But I think actually the carbapenems may be better. The fact that you have cultures from the blood that are positive and OR cultures that are negative or negative to date makes me suspicious that you said he had a PICC line that was removed and afterwards he stopped being febrile. That makes me think, this might have been a line infection. The Acinetobacter might have been a line infection. The OR the so um hmm
Yeah, it's challenging, right?
I don't
Let's see.
yeah.
I think Kevin's trying to decide what order to pull off antibiotics or what to narrow him to. I'll tell you that we did review. So we'd like to hear your thoughts. I don't think there's a right or wrong answer to this. What order would you pull off antibiotics for him? If you just, I think this is a word cloud again. So if you want to type in the name of the antibiotic that you pull off first, that would be great. If you have thoughts about what to pull off. Yeah. Oh, this one isn't. Yeah. There we go. Yeah.
The
This one's a free
micafungin,
text
I
response.
agree.
Yeah.
That makes a lot of sense. Micafungin and the metronidazole, daptomycin.
Yeah.
Yeah. I think Mica and Dapto are definites. Metronidazole, unclear. Especially if you're going to continue to use Abicaz, it has no anaerobic coverage, or very little. Actually, all the trials using Abicaz used Abicaz plus metronidazole because they weren't certain about its anaerobic activity. Considers penicillin skin testing. Someone's really thinking, second order. But yeah, absolutely, because that will help you peel off a lot of antibiotics that he probably doesn't need.
Yeah, so I'll tell you what we did. We reviewed the antibiogram for our hospital after we saw it grew Acinetobacter species. And actually, the best antibiotic at our institution to treat it was actually cefepime. So we placed the patient on cefepime because it actually worked better than Avicaz or ceftazidime avibactam. And then we worked on pulling off other antibiotics. We talked to the hospitalists and the surgical team to make sure that they were on board and aware of our plan. There isn't, I think, a best order for this, but typically, in my experience, I've usually pulled off the micafungin or any yeast coverage first. So that was the first thing that we removed. After that, then we pulled off the daptomycin and then the metronidazole last. So he was just receiving cefepime at the end for his known Acinetobacter bacteremia that we thought was from a line infection. Typically, we pull off antibiotics one day at a time. There's probably no data. There's no data I'm aware of to do that. But it tends to make me feel more comfortable if the patient spikes a fever or has a problem. Doing it sequentially allows us to add back on whatever agent may have been associated with them spiking a fever. Is that what Kevin and Aaron? Is that what you guys typically do as well?
Yep.
Yeah, I think that's
Yeah. So typically, talking with the other teams to make sure that they have buy-ins. What I've done from a stewardship pharmacist perspective, I think talking to the primary team or the surgical team, if you're ideally if you're able to get them both in the conversation at the same time, asking them what they might feel comfortable with, or if they have a plan on narrowing antibiotics, which ones do they think might not be needed? Because some of these antibiotics, especially for a pretty sick person, can start causing interactions. They can develop side effects. C. diff is a concern. Kevin had a slide a few sessions ago that the more antibiotics they're on and the longer duration that they receive antibiotics increases their risk for C. diff. So this person's been on a lot and has a major antibiotic exposures too. So his risk for C. diff is, very real. So his operative cultures actually grew pan-susceptible Pseudomonas too. So in terms of management for that, he's on cefepime now. In terms of agents for him, the cefepime could cover both. One of the questions that we thought about, or I was considering to ask you guys, is if this isolate wasn't susceptible to cefepime, or if you had one isolate that was resistant to your preferred antibiotic and another isolate that was susceptible, how would you manage that? Would you use two different beta-lactams? Would you use one beta-lactam and a fluoroquinolone? The Pseudomonas obviously was, you can't treat with trimethoprim sulfa, but Acinetobacter you can sometimes. So in that setting, especially with a patient with bacteremia, would you trust something like Bactrim for a bacteremia?
Generally, no, but I don't think there's particularly good data to support that. Bactrim, especially if you've removed the source, in which in this patient it sounds like the line was the source, that may be reasonable, though I think a lot of people would be hesitant to do so in terms of using trimethoprim sulfamethoxazole or Bactrim. Beta-lactam and Cipro tends to be the most common combo, because people, it's not very elegant to use two beta-lactams at the same time. If you can use one that covers both, of course, that would be better. But I think a lot of people just end up using one beta-lactam and ciprofloxacin, especially if it covers all your bases, just because it seems like a less of a pain. Also, the beta-lactams are likely going to be IV, and then if you have two beta-lactams and they're infusing two different antibiotics, which can sometimes be extraordinarily cumbersome. And so Cipro, being an antibiotic that you can give orally, tends to be a popular and relatively easy combination. One beta-lactam, cefepime, and ciprofloxacin. But I don't know if there's any data necessarily supporting that as the ideal combo, just something I've seen used all the time and seems to work okay.
Yeah, I agree. It's a terrible answer, but two beta-lactams just doesn't feel right. And that's something that's going to set off alarm bells. If you've got a pharmacist who hasn't been involved with a patient and they see that order, they're going to be trying to understand that. But I don't think there's a reason that you couldn't do it in a case like that if you've got two different organisms that you need to treat. But I think then probably what would be the decision maker for me is looking at what two drugs you would want to use ideally, and then looking at the dosing and the administration of it and what's going to make the most sense that way.
I will say I've almost never, I think once, I've seen somebody have an adverse outcome from two beta-lactams on at the same time. In terms of seizure, which is, I think, the thing that people are most worried about. The likelihood of that as an adverse reaction, even with extraordinarily high doses of beta-lactams, is almost zero. I've seen it so rarely. So just be aware, like it's not elegant. Nobody really wants to do that, but if you have to, there's no law against it, and honestly, there's very little downside if you need to use 2 beta-lactams.
Yeah, I think those are great points. The other thing, just to move things along, because we have to be cognizant of time, is this patient had hardware in place too. So one of the things we were thinking about in discharge is how long you treat someone when they've got hardware in place. So there was a survey to infectious disease providers asking them, and the answers were all over the board because there isn't great data for this. About a quarter said I'd treat them for several months. A third said years. And 40% said that they should get lifelong antibiotics if they've got an infection with hardware in place. And the thought is that hardware allows the bacteria a place to hide so that the patient will be at risk for persistent infection or recurrent infection once antibiotic therapy is discontinued. There's really limited data for other conditions. So some of the orthopedic surgeons here do debridement, antibiotics, and implant retention, which is also called DARE for short. You might see that if someone's adding rifampin on to antibiotics. The most of that data is for Staph aureus. In our cases, we'll also sometimes continue antibiotics until the bone heals if they had an open reduction and internal fixation with hardware that was placed because of a broken bone. And many of our providers at our institution are switching from kind of lifelong or years of antibiotics to roughly 1 year of antibiotic suppression too. This probably is less pertinent in acute inpatient settings, and unless you're seeing someone in the hospital that is admitted for some other condition and they've got long-term antibiotic suppression on for one reason or another, you may have an opportunity to ask them whether or not that antibiotic is still needed, especially if it might interact with other medications like anticoagulants or other medications that they might be on as well. So be happy to hear any questions about case 1, and then we'll go on to case 2, which is a bit shorter as well. We'll give you a minute or two to ask questions about it. That was a challenging one, so I want to thank Kevin and Aaron for entertaining me and struggling with some of those challenges that we regularly deal with on the wards when we're seeing these difficult patients.
I will say DARE, the debridement and implant retention strategy was primarily tested on very early infections, so not people with chronic hardware-based infections or infections that have been sitting around for quite some time. Most of them were relatively new right after the initial implant, and they also had very long tails in terms of how long people kept the patients on antibiotics before they stopped. So just so people are aware of how that strategy was initially conceived. It's getting more and more popular. So because the dangers of the actual surgery are so high that people consider the downside of having a chronic infection or having a significant likelihood of a long-term chronic infection may be better than putting, say, a elderly person through another months of rehab and everything like that.
Thanks, Kevin. Those are great points. So we'll go on to case number 2. This one's made up, although we see these patients pretty frequently, and I'm sure you see some in the hospital too. So this is a 41-year-old female with a history of poorly controlled type 2 diabetes who's presenting with drainage and ulceration from her left foot. X-ray in the emergency department is concerning for acute osteomyelitis. The ED places the patient on vancomycin and piptazo or Zosyn. In this setting, they're in a smaller hospital, so they're admitted. All the admission orders are through the emergency department. And the hospitalist is busy in the morning and is going to see the patient in the afternoon. But in the meantime, the patient comes up on your list to review antibiotics. So what antibiotics would you give or recommend for this patient? I didn't give you a lot of information. There's not a lot of culture data at this point or anything else. This person just came up to the floor. Do you like that antibiotic regimen? I think this is a word cloud one, so type in the name of the antibiotic. I also didn't give you healthcare exposures too, which probably plays a role as well. For a type 2 diabetic without a lot of healthcare exposures, you might try to get away with narrower antibiotics. Yeah, you need more information. Some people said none. That's a good point too. If they had called us, we probably would tell them to hold the antibiotics until they got a bone biopsy. If we thought they'd need long-term antibiotics as well. Some of those plans get screwed up in the emergency department too. In that setting, it's somewhat challenging to figure out what to do or if a bone biopsy will still be useful. In my experience, if they get a short duration of antibiotics, like 24 hours, they usually still will grow something from a bone biopsy. So you still probably have a chance to try to get a surgeon to see them, or a podiatrist, or someone to give you operative cultures from a clean OR site.
Right. But needing information is pretty important. You need to know if they're sick. You need to know if they've had antibiotics before.
Yeah. Those are great points. Some people would do orals for that too, to see how they do as well. She sounded kind of sicker. And then how long would you give antibiotics for diabetic osteomyelitis? Yeah, so it depends. Yeah. There's usually it can range. Yeah.
4 weeks.
Depends on surgical intervention. Yeah, 4 weeks, 6 weeks we'll oftentimes see too. I think 4 to 6 weeks is what's listed in the guidelines, although if they don't have surgical interventions, some people will do a longer treatment duration too.
If they're on orals, oftentimes it'll be months sometimes.
Yeah, that's true. Yeah. So I agree with you. I think all the thoughts that people had were great too. In terms of antibiotic treatment duration, we'll usually do, I would say at our institution, the average is about 6 weeks for most of the patients where we see a diabetic foot infection. Some people some of the ID providers will push for a biopsy if antibiotics have already been started, but oftentimes they'll receive empiric ones. Vancomycin would be difficult to dose potentially for outpatients unless they had a pump as well. So we'll say that you had a hard time convincing the orthopedic or the primary team to narrow antibiotics, and they've improved on whatever you were to convince them for. You still don't have great culture results. And the hospital now wants to discharge the patient on IV antibiotics for 6 weeks, but the patient has insurance issues. So that would make it challenging for them to go home on the IV antibiotics.
Oops.
So
did it not? Oh yeah.
There we go. So what antibiotics would you recommend in that setting? Should they stay in the hospital the whole time? Can you switch them to oral antibiotics? Yeah, doxycypro is a common one that we see, or doxyaugmentin will do. Yeah, oral's an option. We'll talk a little bit more about some of the data for oral too. Some people do Bactrim augmentin or Bactrim Cipro.
Right.
It's hard, the treatment options are pretty narrow if you want to cover Pseudomonas. And we talked about how fluoroquinolones are becoming less popular, but you don't really have a lot of options, and fluoroquinolones are great for treating bone infections too. They have great oral bioavailability. They have great coverage overall too.
But a ton of black box warnings
Yeah.
nowadays.
And then covering, most people want to cover for MRSA2, so Doxy or Bactrim are commonly used. Linezolid probably wouldn't be something we would recommend because of the treatment duration that's required too. It sounds like people already are aware. Usually in that setting, we can probably narrow the patient to oral antibiotics too. So this was a study that came out in the New England Journal of Medicine in January of this year called the Oral versus Intravenous Antibiotics for Bone and Joint Infections. It's called the OVIVA study for short. And they randomized patients to receive intravenous or oral antibiotics for at least 4 weeks. All of them had received 7 days of antibiotics beforehand. And you can see ultimately they had about 400 or so randomized on each group and did a per protocol analysis. So a pretty rigorous evaluation for these patients. And they really selected a wide variety of infections and things that usually are associated with people that are pretty sick. So spinal osteomyelitis or epidural abscess, prosthetic joint implants, debridement and implant retention like we talked about before, chronic osteomyelitis, which was the most common and consistent with this patient just having a kind of garden variety osteomyelitis case. And ultimately, they found no difference in outcomes in the intention to treat, modified intention to treat per protocol population. Because they knew that these results would be somewhat controversial, they also did an analysis for the worst case using a sensitivity analysis too. And they found no evidence that intravenous antibiotics would be better than oral. So for a lot of these patients, after about a week or two of IV antibiotics, they could be narrowed down, especially if you've got susceptibility data down to an oral agent as well. And I think that's a powerful tool to convince your hospitalists or primary care doctors to follow stewardship. So a lot of times on a stewardship perspective, we're trying to convince them of doing something that they might not feel comfortable with. But this could be a setting where it's a win-win, right? This could reduce patient census for hospitalists, so they'll round on fewer patients the next day. This is going to reduce pharmacy cost for antibiotics. Oral antibiotics are almost all universally less expensive than IV antibiotics, so if the patient needs to stay in-house. They're going to have fewer adverse events from antibiotics too, because the orals in large, you're probably not going to have the patient have PICC lines where they would have DVTs or line infusion issues or problems that come up with placing PICC lines as well. And that's going to improve patient satisfaction too, especially if they get discharged early. So kind of the point of this slide was to, or this study and that case was to describe how oral antibiotics are probably an option potentially even earlier than we oftentimes think. So in that patient, we were kind of forced to think about oral agents when the patient had insurance issues. But even for patients with insurance, oral antibiotics could be considered fairly early as well. I know our group is doing that more and more, where sometimes they're discharged and then transition to oral antibiotics in the hospital. Oftentimes it's in clinic. I've been pushing to do that for many of my patients that I see too, including some that I have on service at the moment, especially patients where they think they have a superficial infection. So I've had several of those where we've put them on the exact antibiotics that you guys have recommended. I like using doxycycline quite a bit, so I've had several patients get discharged on oral doxycycline. And I think their outcomes are great. Patients are always happy to hear that they're going to be in the hospital for a shorter duration than they expected to. So I'd love to hear any questions for case 2. That was kind of a shorter one with less to discuss and fewer problems with it.
but a very common case. And I think
Yeah.
Oviva has really, even in the half year that it's been out, it's changed the paradigm quite a bit. It also confirms something that I think a lot of people who deal with osteomyelitis quite a bit have suspected for quite some time, that there really is much less of a difference between IV and orals, especially the highly bioavailable oral agents, than was initially sort of considered. A lot of the information that led to the standard practice of using IV agents for any deep-seated infection, those occurred at a time where there weren't really randomized controlled trials, and the agents were just very, oral agents were terrible. And we're not in that same era at this point.
Yeah, those are great points, Kevin. So just to be aware of time, I want to close things up so everyone can go to their 11 o'clock meetings and other things. Thank you very much for attending this series of webinars. We would love to get feedback on this webinar too.
So,
and Kevin, go ahead.
Yeah, so this is going to be the last webinar of the 2019 MASEC season. As we said, MASEC was not renewed. The funding for MASEC was not renewed this year, though we're hoping to apply again in future years. We will be putting together, I think, some lower effort, but hopefully just as useful resources. So the lectures will remain on the Missouri Department of Health website, and the emails, the email contact point, moststewardship@worcester.edu, will remain open for questions that we may not be able to provide as prompt answers. We are also putting together, as Mike mentioned earlier, a listserv for all the practitioners of stewardship in Missouri to hopefully talk amongst themselves. And you'll be getting an email from the Most Stewardship contact point sometime probably in the next month or so, sort of defining what the new listserv is supposed to be for, what kind of information can be placed on it, and how to sign up for the listserv. We're going to use the people who were participating in the MASEC conferences just sort of as a starting point for people who are interested. You'll still have to sign up, so you won't get bombarded by emails unless you want to. And we're not expecting this to be an incredibly high volume listserv either, but it will help us all sort of bounce ideas off one another and share success stories, frustrations, possible strategies for improvement, things of that nature. And so hopefully this is not the end of MASEC, though it is the end of this season of MASEC, just like the last year's was. And we'll see. Stay tuned and keep your eye out from emails from our Most Stewardship email about new projects or new possibilities for stewardship education and data sharing going in the future. It's been a pleasure. It's been my pleasure to help program MASEC and make sure that everybody was happy with what was being produced. And I think Mike and Erin what do you guys feel about how this has gone? Oop.
I have enjoyed interacting with all of you guys out there that are doing the frontline work of antibiotic stewardship.
Right.
So I've appreciated the opportunity, and hopefully we'll be able to come back at some point in the future so we can be involved with you all again.
Right. It's been a pleasure, and I hope these have been helpful. Please feel free to send us, emails saying that we did a good or terrible job. We're very happy to hear about it. And we'll hope to talk to you guys again, hopefully not in not that far in the future. Have a great day, everybody. It is a great day out in Missouri today. and you'll hear from us soon. Thanks,
Yeah, and
everybody.
then
Oh,
yeah,
yeah.
it's been great. One other thing too, the CDC does care about feedback for these things. So if you do, or if you've really enjoyed our program and you want to give additional feedback beyond the individual conference feedback, feel free to send us an email on that mo.stewardship website email address, and we will do our best to try to share that information with the CDC in order to get more funding in the future as well.
Thanks, everybody. Have a nice day.
Thank you. Yep, thank you.